Okay. Hi, everyone. This is the first part of a three-part project for Case Study A, presented by Alexia, Ariana, Io, Bethany, myself, Kevin, and Will. This presentation will introduce our patient scenario, but the primary focus is to build an understanding of the underlying pathophysiology, epidemiology, epigenetic, and psychosocial elements of stroke. Using this foundation, we have developed a nursing health assessment and plan of care that will be detailed in other two parts of the project. Moving on, I'm just going to do a quick little dive into our case study. Our patient, Clarabelle Newington, 72-year-old female who was admitted to the emergency department due to sudden onset hemiplegia, aphasia, and urinary incontinence. A CT scan confirmed a left-sided ischemic stroke, and her most recent vitals are a blood pressure of 190/100, a heart rate of 120 beats per minute, a respiratory rate of 18 breaths per minute, and a temperature of 96.8 degrees Fahrenheit. She is still experiencing right-sided paralysis, aphasia, and urinary incontinence. She requires repeated stimulation to maintain consciousness and is currently unable to obey commands and quite disoriented. Due to her inability to communicate at this time, her son is acting as the primary point of contact for collecting her health information. And just some additional background, she lives alone in a retirement community and was found by her son. She is a devout Catholic and an avid churchgoer and requires a special diet in order to observe Lent. Her religious beliefs and dietary restrictions are being taken into consideration for her assessment and plan of care, and the hospital chaplain services have been contacted. With that, I'm going to hand it over to Ariana to discuss the broader significance of stroke.
Hey, everyone. So stroke is the sudden onset of loss of neurological function in the brain, retina, or spinal cord caused by focal infarction or hemorrhage. In the case of Clarabelle Newington, she's experiencing an ischemic stroke, which is the blockage of a blood vessel in the brain causing significant damage to the brain. A stroke is always considered to be a medical emergency due to how quickly the damage can occur to the brain tissue from hypoxia. This damage can cause long-term disability and, in the worst case, death. The leading risk factors for stroke include high blood pressure, high cholesterol, smoking, and diabetes. These will be expanded on later in the slides. And the prevalence of these risk factors is also high, making stroke the 5th leading cause of death in the US and the 6th leading cause of death in Arizona. On the next slide, so from the CDC's Atlas of Heart and Stroke, we can see the highest prevalence of stroke-related deaths in the northwestern and northeastern regions of Arizona, here in the very dark purple. These have a mortality rate of 370,000 to 400,000, and the study was done between 2018 and 2020. And to bring it a little closer to home, we can turn our attention briefly down towards the southern region where we see Tucson. In this region, between 2018 and 2020, the stroke death rate fell between 320,000 and 340,000. On the next slide, we'll see the rates at a national level. So among the states, Arizona is ranked the 33rd lowest for stroke mortality rate. And you can see a lot higher concentration on the eastern coast, partially due to a higher population in that region. But overall, despite our ability to provide quick and effective care, the mortality rate in the US for stroke has increased by 230,000 between 2020 and 2021. And lastly, on the global level, on this next slide, we can see these red and orange regions on the right side of the map in Asia, the Middle East, and Africa. There is a significant increase in the mortality rates of stroke compared to the US and Canada on the left side of the screen, and Australia on the lower right. And now I'm going to give your attention over to Brooke for cost.
Okay, so in addition to the high mortality rate of stroke and the high cost for acute care, an estimated 50% of stroke survivors suffer from long-term disability, which often requires lifelong assistance, resulting in a high financial burden in both the system as well as for the individual and their support network. Globally, an estimated 3 to 4% of total health expenditure, that is, all money being spent annually on any disease, is estimated to be spent on stroke treatment, which is roughly $721 billion annually. And just a note here that this is thought to be a bit of an underestimate, just given how difficult it is to gain access to surveillance data in lower and middle income countries, which we saw in the last slide are heavily affected. And then looking just within the United States, stroke is estimated to cost roughly $240 billion a year. And this is expected to continue to increase due to the common comorbidities such as ischemic heart disease and atrial fibrillation, which increase the cost and the complexity of care required. And then looking just at the cost of ischemic stroke alone in the US is estimated to cost around $140,000 per person, which has the potential to be catastrophic, especially for the uninsured population. And with that, I'll turn it over to Bethany, who will dive a little deeper into the high psychosocial costs associated with stroke.
So going into the psychosocial impact of patient, family, community, and population for stroke, I would like to discuss the emotional status of people who are suffering from a stroke. A lot of the things that they can suffer from are post-stroke depression, post-stroke fatigue, post-stroke anger, post-stroke emotional incontinence, which is also referred to as the pseudo-bulbar effect. These all have varying levels of prevalence. Going into finances, the lifetime cost of ischemic stroke was brought up by Brooke, but I would like to break down the percentages for each of the individual portions of this cost. So inpatient care makes up 70% of this cost, outpatient makes up 11% of this cost, and additional costs cost 8%. In terms of education, there is a lot of education that a person has to go through after suffering a stroke to learn and relearn how to work through things. Recovery usually occurs within 3 months of onset, and they have to recover language function through speech and language therapy, rehabilitation of walking through gait training and physical therapy, recovery of upper limb function through physiotherapy, and regain urinary continence through bladder training. In terms of social activities, this particular person is at risk for loneliness as they are likely being separated from their community through being in the hospital and having to likely go to a rehabilitation center. They're also having social isolation as they are no longer being with the people that they would normally be able to see, such as their church community and all of the other people. In terms of sleep disorders, there is a greater than 50% prevalence of sleep disorders for people who suffered from a stroke. Most of these are sleep-wake cycle disorders, including insomnia, which affects the majority of these people affected by these disorders, long and short sleep duration, and circadian rhythm disorders. Okay, and then family relationships and roles. This particular person may be struggling with role performance with their son, as this is someone who they have cared for their whole life, and now that the son is likely caring for them. And their role in the church community has changed because they are likely unable to pass out communion like they used to do and just be a primary member of that community. Survivors retain their leisure activities such as sports and driving in their first year post-stroke. So the likelihood that this individual will be able to go back to their leisure activities right away is unlikely. In terms of employment, this particular individual, based on their age, is likely retired. However, approximately 1/3 of stroke survivors return back to work, with 1/2 of those people changing their jobs because they are unable to return to the job that they used to have. And all of this relates to the quality of life with the Barthel Index score, which measures the ability for a person to go back to doing activities of daily living after 3 months, saying that over half of stroke survivors are moderately dependent and over a quarter are independent after the 3 months. For personal factors affecting the quality of life, this particular individual is suffering from paralysis, urinary incontinence, the inability to speak, and struggling with integrating religious practices. And now passing it on to Cynthia.
All right, so at-risk populations, when looking at the risk factors in regards to gender, women are more likely to experience an ischemic stroke at a younger age due to hormonal oral contraceptives, pregnancy, and the postpartum period. In women, there's an increased risk of stroke in the weeks following birth. In advanced age, women are also at risk if they're receiving postmenopausal hormonal therapy. Like hormone therapy, oral contraceptives contain estrogen, and estrogen assists the blood in coagulating, posing a risk for blood clots. Also, women who are pregnant and have a diagnosis of high blood pressure or preeclampsia are at a higher risk for an ischemic stroke. Moving on to men and women, adults that are 55 and older are at a higher risk for an ischemic stroke, with the risk increasing every decade. And then moving on to racial and ethnic predispositions. So Black and African Americans are 2 times more likely to have a stroke. In some Hispanic Latino American groups, there is an increased chance of a stroke, and Native Americans have an increased possibility of an ischemic stroke as well. And then for genetic factors for ischemic stroke, you will see that the hereditary factors consist of atrial fibrillation, diabetes mellitus, and hypertension. Single gene disorders that primarily cause a stroke, examples are familial amyloid, collagen 4 mutations, and then genetic disorders that include stroke as a manifestation is sickle cell disease, Marfan syndrome, and Fabry disease, and Ehlers-Danlos type 4. Some common genetic variations for ischemic strokes, or that put you more at risk for ischemic stroke, is going to be the TSPAN2 gene, the ABO gene, and the HDAC9 gene. And then moving on to cultural predispositions. So some cultural predispositions that put you at risk or more likely to have a stroke is going to be cigarette smoking and alcohol consumption. And with alcohol consumption, it's usually seen with heavy alcohol consumption associated that's associated with a higher probability of having an ischemic stroke. And then also substance use and abuse of cocaine, heroin, ecstasy, and amphetamines, and obesity, sedentary behavior, and diets high in salt and fats puts you more at risk for an ischemic stroke. And now I'll be passing this on to Will.
Yeah. So I'm going to talk about epigenetic mechanisms and environmental factors that play a part in stroke risk. So epigenetics or epigenetic mechanisms are basically biochemical switches that alter gene expression without changing the underlying DNA sequence that constitutes a gene. And so our understanding of the epigenetic mechanisms at work in stroke is still sort of in its infancy, but it represents pretty fertile ground for further and future research, but doesn't really have clinical implications yet in this moment. There are 3 main sort of mechanisms that are understood to alter the expression of genes that are associated with stroke risk. One example that has had some interesting research around it is the DNA methyltransferase mediated methylation of a gene that encodes for thrombomodulin, or TM. And that's a protein that has these anticoagulant properties because it embeds in the membrane of endothelial cells and acts as a receptor for thrombin. So in that way, it decreases coagulant activity. There's a 2016 study that found that patients who had ischemic stroke had significantly higher TM methylation or methylation of this gene than a control group. And that makes sense because DNA methylation tends to downregulate for the transcription of protein or the expression of a gene. And so it reduced the levels of TM in patients' blood and reduced the anticoagulant activity. It's also worth noting that that study, like many studies into the epigenetic risk factors for stroke, compared a control group to an experimental group that already had experienced stroke. So it's not always clear whether the epigenetic changes or epigenetic differences are down or upstream of the stroke itself. And that's a sort of an open question in a lot of this epigenetic research. Move on to environment. Thank you, Brooke. Okay, so as far as the environmental risk factors, some of the more sort of potent and well-documented environmental risk factors are long-term exposure to air pollution, which is really well-documented, secondhand smoke, moderate or severe ionizing radiation, and then arsenic, cadmium, and lead. Exposure to a lot of these occur at the level of the workplace, the home, or the urban environment. So these are really more the targets of kind of policy interventions rather than individual behavior modifications. And they're also very socially determined. They may mediate some of the socially determined elements of stroke risk. And there are a handful of research into. So those include some research into noise pollution, temperature variability, and even geomagnetic storms. Now, a lot of the behavioral, the sort of key behavioral risk factors were already covered by Cynthia. One thing that's just sort of worth noting, I think, about those and the environmental risk factors that I listed above, and like almost 50% of stroke-related deaths are associated with poor management of some of these risk factors. So this is like a really important target for clinical intervention. And I think Kevin is going to talk to us about the pathophysiology.
All right, let's talk about the nervous system. The nervous system is a combination of complex structures that interact using electrical and chemical signals to allow our body to regulate and control internal anatomy, as well as make decisions and interact with our surroundings. It is the bridge between the brain and the body's organs and tissues. And on the next slide, we'll talk about the cells of the nervous system. Neurons are the primary cells of the system. They transmit and receive information processed by the nervous system. Each neuron consists of a cell body known as a soma, dendrites, and axons. They also contain supporting neuroglial cells, which assist in the functionality of the neuron. Neurons can be sorted into three functional types: sensory neurons that carry signals from the peripheral sensory receptors to the CNS through afferent pathways; motor neurons, which carry signals from the CNS to the body's effectors, such as skeletal muscle, through efferent pathways; and interneurons that exchange signals between different neurons. Neurons generate and conduct both electrical and chemical impulses through the electrical potential of their plasma membrane and by releasing chemicals which influence other nearby neurons. These are known as neurotransmitters and neuromodulators. Neurotransmitters and neuromodulators can be excitatory, for example, with dopamine, inhibitory, such as serotonin, or either, like in the case of acetylcholine. And on the next slide, we'll talk about the central nervous system. The central nervous system contains the brain and the spinal cord. The brain is divided into several different levels of structures, the most basic being the three primary vesicles: the forebrain, midbrain, and the hindbrain. The forebrain contains the cerebral hemispheres, cerebral cortex, basal ganglia, epithalamus, thalamus, hypothalamus, and subthalamus. The midbrain contains the tectum and the superior and inferior colliculi. The hindbrain contains the cerebellum, pons, and medulla oblongata. There are also structures of the brain which consist of multiple structures from different vesicles, such as the brainstem, which consists of the midbrain, medulla, and pons. Within the forebrain, there's a variety of structures. One such is the primary voluntary motor area. Electrical stimulation of the different areas within this cortex cause corresponding muscles to move accordingly. These various different structures and areas of the brain correlate with the physiological functions of our body. The spinal cord is the other portion of the central nervous system. The spinal cord can be divided into vertebral sections with corresponding nerve pairs. The central canal is the innermost space of the spinal cord and is surrounded by gray matter, which contains nerve cell bodies. This gray matter is divided into three areas: the posterior horn, which includes the substantia gelatinosa, a structure involved in transmitting nerve impulses for pain; lateral horn, which houses the cell bodies involved in the autonomic nervous system, as well as the anterior horn, which contains the cell bodies of nerves used in efferent pathways. Surrounding the gray matter areas is white matter that forms spinal tracts, which carry nerve impulses along the spinal cord. Signals which move between a receptor, an afferent neuron, an efferent neuron, and an effector muscle or gland are known as reflex arcs. And next, we'll talk about blood supply of the central nervous system. The brain's blood flow is autoregulated, with the primary regulator being CO2. The main arterial supply of the brain is composed of the carotid arteries and the vertebral arteries. These structures then make up the three major paired arteries which perfuse the brain and brainstem: the posterior inferior cerebral artery and the anterior inferior cerebral artery, and the superior cerebral arteries. Those are the three main paired arteries. The circle of Willis is a structure which allows for alternative routes of blood flow and is formed by the aforementioned arteries as well as the anterior and posterior communicating arteries. And finally, we'll talk about the peripheral nervous system. The peripheral nervous system has two major parts: the somatic nervous system and the autonomic nervous system. The somatic nervous system is responsible for voluntary muscle movement via efferent nerves and sensory information via afferent nerves. It consists of the cranial and spinal nerves. Most spinal and cranial nerves contain both sensory and motor neurons. The autonomic nervous system is responsible for homeostasis and keeping the internal environment at regular conditions. It is divided into the sympathetic nervous system, which responds to stressful stimuli by preparing the body for conflict by regulating vasomotor tone. Then there's also the parasympathetic nervous system, which promotes rest and digestion in the body through several physiological changes, such as heart rate and increasing peristalsis. And next, we'll be talking about the pathophysiology.
All right, we are now going to segue into the pathophysiology. Based on Mrs. Newton's clinical manifestation and CT scan, we were able to determine she experienced an ischemic stroke caused by an occlusion of cerebral blood flow in her left anterior cerebral artery. We attributed this occlusion to a cerebral thrombosis. In ischemic strokes, we see the cellular and resulting tissue changes in the ischemic core and the penumbra due to deficient oxygen and glucose supplies. In the ischemic core, cell death can happen within minutes. This is the main site of injury, and the neuronal cell bodies, axons, and nuclei will disappear. In neuralgia cells, the cytoplasm will swell and the nuclei will also disappear. In the penumbra, the borderline hypoxic area surrounding the ischemic core, endoplasmic ribosomes and Nissl bodies disintegrate. This area will not die immediately and can be recovered with early intervention and reperfusion. There is a 3-hour window after initial injury to save the penumbra. All right, next slide.
All right, thank you, Cynthia. So returning to the functional changes that Mrs. Newington is experiencing, we are seeing contralateral hemiplegia on the right side, akinetic mutism, aphasia, and urinary incontinence. The paralysis occurring on the right side indicates ischemia to the structures on the left side of the brain. And because we do not know how much time passed between the onset of Mrs. Newington's symptoms and her discovery by her son, so we're assuming that the penumbra is going to be lost. And looking at this image on the slide here, we're able to see what parts of the brain are perfused by the anterior cerebral artery in yellow, and which regions are likely being affected in Mrs. Newington. So the primary structures include the basal ganglia, the corpus callosum, the medial surface of the cerebral hemispheres, and the superior surface of the frontal and parietal lobes. These areas house parts of the primary sensory and primary motor cortices, as well as the frontal, prefrontal, and supplementary motor cortex. And with that, I'll turn it over to Alexia, who's going to go into more detail on the damage occurring.
All right, so the cellular, or as Cynthia mentioned, the cellular changes that occur in the ischemic core begin minutes after the arterial blood flow is occluded. The neuronal cells are deprived of oxygen and glucose, which leads to mitochondrial dysfunction in the production of reactive oxygen species. ROS causes oxidative stress and cell damage. Further, the lack of oxygen and glucose contributes to acidosis and an ion imbalance that causes cell depolarization and glutamate release. The excess glutamate activates a group of receptors that induce toxicity and cell death. In the ischemic core, we see unprogrammed cell death, characterized by irreversible necrosis, which is caused by a decrease in ATP. In the penumbra, we see cell injury and normal programmed cell death, or apoptosis and autophagy. The injured and dead cells in the core and the penumbra release DAMPs, or damage-associated molecular patterns. The DAMPs are recognized by other immune cells and activate numerous signal pathways. 1 to 2 hours after initial stroke, the pathways activate microglia. The microglia stimulate the production of cytokines, notably interleukin-6, interleukin-1 beta, and tumor necrosis factor alpha, all of which induce neuroinflammation. Another notable change is the upregulation of adhesion molecules that allow leukocytes to attach to vascular surfaces and infiltrate the blood-brain barrier, or BBB. The infiltration of immune cells and further release of cytokines leads to an increase in the permeability of the blood-brain barrier. And after about 3 hours, we see the total breakdown of the blood-brain barrier, and that's brought on by MMPs, or matrix metalloproteinases, and inflammatory mediators. The breakdown leads to vasogenic cerebral edema. We see multiple cellular changes happening simultaneously and an intense immune response when a patient is afflicted with stroke. 1 to 2 days after the stroke, the immune response continues with the arrival of T cells at the site of injury and the release of various interleukins. Weeks after the initial injury, B cells in the area are producing antibodies against brain molecules, which can delay the healing process and aggravate the initial injury. The resulting tissue damage can lead to permanent tissue death, or if reperfused, more tissue damage. This results in the manifestations we see in Mrs. Newington. Ischemic stroke has features of both chronic and acute disease. It's considered acute due to the amount of time it takes for damage to occur. Again, as we've mentioned, permanent damage can occur in minutes, and the onset of symptoms is generally sudden. Additionally, patients can see a resolution of symptoms in some cases in as early as days, and this is common with TIAs, or transient ischemic attacks. The potential permanent damage and resulting physical, mental, and emotional effects of ischemic stroke are arguably a chronic product of the condition. And so we can say that ischemic stroke starts out as an acute condition and can become a chronic one. Io is going to speak to you now on some emerging and current research.
Okay, so for emerging and current research, right now, recanalization and reperfusion are the go-to methods of treatment for stroke patients. The main part of this is reestablishing blood flow either by surgical removal of blood clots or pharmacological thrombolysis. Mainly right now, adaplase is the only thrombolytic used for this, but there's a lot of promising research indicating that tenecteplase might even be a superior thrombolytic to that, reestablishing blood flow more effectively. Involving stroke nurses has been shown to decrease the amount of time it takes between the patient arriving and receiving treatment. And with stroke, quick treatment is really the main factor. Next slide, please. So research is also showing that patients with obstructive sleep apnea are more prone to experiencing ischemic stroke. So one of the mechanisms involved there is that typically while we're sleeping, our blood pressure is a bit lower than during the daytime. For OSA patients, the sympathetic nervous system is often being stimulated during these apneic episodes. And so you're actually seeing significantly elevated blood pressure after an apneic episode. And so that's it kind of increases the hypertension risk that often leads to stroke. And so increasing screening and treatment of OSA is really important for helping to reduce incidence and improve outcomes. CPAP is known to be a pretty effective and accessible treatment for a lot of patients. And this on the side is kind of indicating some different factors influencing access to screenings. And the next slide, please. And as Will mentioned earlier, so epigenetic research for stroke is really in the early stages. There are those three factors, with DNA methylation really being the bulk of the research currently. And that DNA methylation is thought to have a role in regulating the suppression of gene expression. Go to the next slide. And so this figure right here is showing giving you a visualization of these different mechanisms. So at the bottom here, you can see the DNA methylation. You can see the groupings of the methyl groups on the strands, a lot of the times grouping around the CPG islands. So the more that you're seeing methylation, the more genes are being suppressed, and with less of the methylation, the less so. And we can move to the next slide. And then just one thing related to DNA methylation in research. They did a study on mice recently, looking at leakiness of the blood-brain barrier. After stroke, the blood-brain barrier can leak for months after for some patients, and which can lead to higher levels of long-term disability. And so they did find that particularly older mice had higher levels of altered methylation, which really affected the brain's ability to reform vasculature through angiogenesis, and essentially contributed to the prolonged leaking of that blood-brain barrier. There is some thought that potentially contribute to creating therapies that can reduce that long-term disability that happens due to leaking of that barrier. And then next slide, I think we're just looking at our references. Thank you so much. It's been our presentation.